Suman sir?
Sure. So, good evening all. Shuman on behalf of Shield Healthcare, welcoming you all in today's TNFOG Marathon CME on video session on scope. So before starting the session, let me introduce our MOC. Professor Dr. Sampath Kumari Madam, as you all know Madam, and it's my honor to introduce Madam once again. Madam is the Chief and HOD, Muthukumaran Medical College and Research Center, Chennai. And Madam is the Vice President elect FOXI 2022. She is the Founder Secretary TNFOG, National Correspondent Editor JOGI. And Madam is the Senate Member Dr. Enshir University, and she is the Chairperson FOXI Adolescent Health Committee. And she is the DIE Director and Professor Obstetrics and Gynecology, retired from Institute of Obstetrics and Gynae Medical College. So with this short introduction, I request Madam to take over the session for further proceedings. Thank you very much, and over to you, ma'am.
Thank you, Dr. Suman. Good evening to all. As all of us know, every month, second Friday, we conduct this Marathon CME with taking one topic as a theme of the CME. This month, we have taken the video session, preferably with one with colposcopy and another one with the hysteroscopy. We have two eminent people in that field, Dr. Priya Ganesh Kumar for colposcopy demonstration and Dr. Vanita for hysteroscopic demonstrations. So with this, I welcome our President, Dr. Anjalakshi Madam for the presidential address and welcome address.
Now, before that, we have the
yes, Madam.
Tamil
Go with Tamil Thai Waltz and lamplight. Yes, Chitrakala.
எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Thank you, Chitrakala. Now
Yes,
I introduce Dr. Anjalakshi Madam. She is the president of our TNFOG Federation, and she was the past president of OXI, and she has her PhD in the diabetes, and she has retired as a professor from IOG and Mada Medical College and many other colleges. Back to Dr. Anjalakshi Madam. Only one thing missing in our Marathon CME this time is we didn't release the newsletter due to some administrative problems. So then with the next month, we can have the newsletter. Thank you. Anjalakshi Madam.
thank you, Dr. Sampath Kumari. Good evening to everyone. It is my pleasure to give the welcome address. Today, we are going to have the interesting visual learning video session on the scope by eminent speakers, Dr. Priya Ganesh, who is going to show the various colposcopic features of pre-invasive lesions of the cervix. She is the Sorry for the interruption. She is going to show us the various colposcopic features of pre-invasive lesions of the cervix. The colposcopy helps us to identify the pre-invasive lesions and treat them early so that we can primarily prevent the CA cervix. And also we are going to have the demonstration of various procedures by hysteroscope by Dr. Vanita, who is a master in the hysteroscope. And now we are in the era of the office hysteroscope, where the hysteroscope is being done in the OPD itself. And most of the patients with the AUB, they go with the diagnosis on the same day as their OP. And it has become a must. The hysteroscope has become a must in the infertility evaluation. So both the demonstrations are going to be very interesting. And for this, I cordially invite Dr. Revati Janagraman and Dr. Vidya to chair. And the speakers, welcome the great speakers, Dr. Priya Ganesh and Dr. Vanita. So I welcome the delegates and request them to actively participate in the video session to recollect what we have learned already and to improve their knowledge. I wish the CME a great success and the delegates to enjoy the program and have a wonderful evening. Jai Hind.
Thank you, madam. Now we will straight away go to the scientific session. Priya, if you are ready, we can start that program. You are 10 minutes earlier. No problem, no?
No, I'm ready. Perfectly ready.
Yes. So I take the pleasure in introducing our chairpersons, Dr. Revati Janakiraman. Madam is the incoming president for TNFOG, and she was the past president of Madurai Society, and she was the past director of IOG, and she is the founder secretary of Madurai Society and the Madurai IMS chapter. And madam is a good teacher and she has many awards to her credit. Welcome, Dr. Revati, madam. Next. Dr. Vidya. Dr. Vidya is she is president of Salem Society, and now she organized the wonderful Yuva Foxy conference of Foxy in Salem 2 months back. It was very, very wonderful. Thank you, Vidya, for involving all of us. And she is interested in high risk and infertility. Dr. Vidya, welcome. And both of you, I request the chairperson to start the session.
Thank you, ma'am. Thank you, ma'am. First of all, I would like to thank the TNFOG organizing committee, Dr. Anjalakshi madam and Dr. Sampath Kumari madam for giving me this honor. In fact, I feel very much humbled to be with all great persons like you. And it's my pleasure and honor to welcome Dr. Priya Ganesh Kumar. Can we have her CV, please? Actually, I got associated with Dr. Priya Ganesh Kumar about probably, when she was running for her elections. And she is one person who's really impressed me along the way. And I think it is the same with most of the people she has become associated with. They've all been, her fans. So let me just read it out. I'm sure most of you know about it. She is the Foxy Oncology Committee Chairperson 2021 to 25. She's a medical director of Sai Nivas chain of preventive oncology centers pan India. It's a chain of 30 preventive oncology centers. Mentorship and training, WHO, IARC, IFCPC colposcopy and cytology course trainer for India. In fact, she has trained hundreds of gynecologists all over the country. She is the official master trainer for the course in colposcopy via and preventive oncology for National Health Mission, Government of MP under Ayushman Bharat. She is a PhD guide as well for Bharatiya Vidyapeeth University, Pune. She's got a lot of publications to her credit. One of them is she's the author of Atlas of Colposcopy and Cytology, authored by Dr. B.K. Iyer. Official reviewer for Jogi Foxy Journal Oncology section. She's got lots of awards and recognitions. I think if I start talking about her, I think we'll run on to pages. So without much ado, I would like to welcome Madam. Madam, the floor is yours.
Thank you very much, Vidya. In fact, I also shared the same feeling, during the election time, I became close with you all. Now I become fan of yours and everyone. So TNFOG is not new to me. I feel always so connected and it's like my organization, I feel inside it. So whenever Dr. Sampath Kumari or Dr. Revati or anyone, calls me up and says, I want you on this program, Ottakal, I'm saying yes, I'm ready for it, whatever my time be. So thank you very much to invite.
Thank you, Priya, for that. Thank you, Priya.
Yes, madam. Yes, madam. Thank you, madam. And I'll start my, I'll just share my screen.
Always thank you, Priya.
So sweet of you, madam. Siriyarda, my screen is visible.
Yes.
Then go to slideshow. I think. Yes.
Yeah.
So I brought this, this topic as third eye of gynecologist. And let's see how we can make a benefit of with the third eye of gynecologist, which I normally call this as colposcope, as Shiva has his third eye. So gynecologist also has the third eye, like, colposcopy. So today's talk goes with videos on that, and also how do you understand it in a better fashion. I bring greetings from my Mumbai clinic and one at Delhi also. Now, to start with the deliberation, the beautiful truth about women is I think women are foolish to pretend they're equal to men, but actually they are very far superior to them. And that's the reason why we also feel very highly great about ourselves, that we are women and we are serving women. So when it comes to women life, we all know that really they come to us only a little late, when the stages have really gone beyond, and that's the time they give importance to their own health. Otherwise, they do not. So before even we start with this deliberation, I would like to bring forth Louis Smith's wonderful statement stating that you can't reach for anything new if your hands are still full of yesterday's junk. So let's wash out and let's clear our cup and sit to understand the new things. I am sure colposcope is not new for us anymore, but the nuances are there which can be picked up by the youngsters and, hone the skills of colposcopy. Knowing the fact that cervical cancer is shouting at the top of the voice, that you may know me, you don't require a big, specialist to understand a cervical cancer. You see a growth and you take a biopsy and you know about it. But where does we as a specialty truly put our focus into? So our focus, and as a specialty of gynecologists, we do have the privilege of understanding colposcopy in a much better fashion. And that's where exactly we are serving our women clients by understanding the precancerous conditions, which they are so much hidden. I mean, can't be seen. Otherwise, you have to use certain tools to understand these precancerous lesions. Treating them, hysterectomy is not the answer for precancerous condition. So you treat them in a better fashion so that you never see your client or a patient going to cancer. In fact, when I started my practice 3 decades back and around 2.5 decades back, I was more focused into colposcopy. Something which to jitter me from inside, my soul used to get jittered when I used to see a cervical cancer patient sitting in front of me, and we giving the only the years to count, saying that, oh, you will live for so many years, or you go here, you go there. We don't become a traffic police, isn't it? We have a role to play, and we certainly do have. And if we can actually understand this precancerous condition in a better fashion, definitely the time is different when we will not be saying this statement that 1 out of the 4 women dying due to cervical cancer is an Indian. Knowing the fact that the Globacon 2020 has shown a raise in cervical cancer statistics, it is amounting to 18.3% of all the cancers in the female. And again, it is mounting to second most common death because of cancers. So now it's like the rates have increased. If you would have noticed the Globacon 2018, the cervical cancer was incidences was 96 and deaths were 60, around 60,000. Now you see within 2 years where the rates have increased. And also when you talk about cervical cancer, the deaths, we see a lot of deaths compared to the breast cancer. Now you see the incidences of breast cancer, incidence of cervical cancer, the difference is just 7. But if you see the mortality, the difference is just 2. Why? Because we see in our country, again, cervical cancer is a very symptomless condition. We see the symptoms only when we have when the patient has a cervical cancer. So the symptoms for precancer is also not there. I just mentioned to you about this Globacon 2018. So we have a methodology for elimination, which has been given by the global strategy call, WHO call, 90, 70, 90. We all are now adept to this sentence. Many of us have used this n number of times in our deliberations everywhere. So it's like 90% coverage with vaccination, 70% of the screening with high performance tests, like HPV becomes a high performance test. So what WHO says, that if you want to achieve an elimination by 2030, that is, elimination is less than 4 per 100,000 women, if you do want it, even if you're able to tackle 70% by, twice in a lifetime, 35 to 45 years with an HPV, it will make wonders. And then 90% is treatment of the precancerous or the cancerous lesions. Knowing the fact that HPV, we know this very well now, it's a established fact, and we have vaccinations for it. We have low risk and high risk HPV. And the most surprising part of an HPV is you do not have to have penetrative sex. That's one thing which you have to understand. Skin to skin contact also can be, transmitting HPV. And again, another thing is, out of 5, 4 women in our country do have an HPV virus sometime or the other in the lifetime. We don't know, but we don't have to get scared about it, because HPV is such a virus that it regresses on its own most of the time. And hence we have to have them under surveillance. And 16, 18 being the most causative factor for it. So what happens with an HPV is, whenever there is a lesion, many times it regresses, but certain times it progresses, and there is a precancerous condition which we can identify with a colposcopy or with certain screening techniques, and then treat it. So what is a CIN? A CIN is it's a cervical intraepithelial neoplasia. That is a neoplasia, a tumor within the cells of the cervix. So it's absolutely a precancerous condition. You don't have to worry. And if a patient comes to, even now, when I see patients, I would have done more than 75,000 colposcopy or more. And with my centers across the country, with 30 centers pan-India, we have in fact identified more than 60,000 CIN cases. We have treated them, and we have saved them from going into unnecessary hysterectomies and from going into unnecessary, leading back to the cancers and all that thing. So the understanding of this subject is pertinent to make the real utilization of this subject. This is where exactly we know this thing, that we have this green zone to tackle. We have to understand in a better fashion. And so today I am with you all, making you understand about the precancerous conditions. And in fact, when I said third eye of gynecologist, I in fact took it up from this picture, that what is the mystery of the third eye of Lord Shiva? He can see things which are not seen by others. That's exactly what a colposcopy can get to you. And knowing the fact that Singer Monahan also had stated it very beautifully, that colposcopy with a directed biopsy is a gold standard. We do have to understand certain terminologies before we venture into understanding colposcopy and started interpreting colposcopy results. And all these things are very simple ones. These are real basic ones, but they have to be understood in the right perspective for the clinical implication of these terms. So squamous epithelium looks more pink in color because of multiple layer and is thrown into folds, which is called stromal papillae, which is the invagination of the blood vessels. This gives us the basis for punctation, because you see through colposcope, you see the head-on view, and you try to see the cut section of the blood vessel. So a fine caliber blood vessel will look like fine punctation, or a high caliber blood vessel, which is actually providing nutrition to the dividing cells. They are high bore blood vessels, and they look like, coarse punctation. Now coming about with columnar epithelium, many times we have come across doctors telling that, oh, you have an ulcer, you have an erosions. All these terms are not there. In fact, there are no terms like erosions in a colposcopy world. And we will be, why do you look like an erosion? Because the columnar epithelium is single layer, it's red in color, it's thrown into folds, and that looks granular, that looks reddish, angry looking. So that doesn't mean that it's an erosion. It's only that it's a columnar epithelium which is outflown till an ectopion, ectropion. Understanding SCJs are again a very important thing for all of us when we do a colposcopy, and it's the transformation zone, because it's in the dividing cells that the lesions are actually manifested. So coming to this fact that first the SCJ is the primitively is in the prepubertal area in the endocervix. Then because of the advent, we all know about this, the advent of the physiological hormones, estrogen and all that thing. Now it is growing, and where will it grow? It can't grow on the uterus, right? It has to go find a least resistance pathway, and that's where it outflows. And the first SCJ, original SCJ, is found as a crypt opening. That's the basis of understanding transformation zone. And then you have those whole single-layered epithelium bathed in vaginal pH, acidic pH cannot take that brunt and hence has to get converted into multiple layer. And that multiple layer conversion is called metaplasia. Even today, I get a lot of phone calls from everywhere stating that, madam, my patient has got metaplasia. Shall I go ahead doing definitive surgery like hysterectomy? But that's not required because metaplasia is just a physiological manifestation of conversion from one epithelium to another. It's called squamous metaplasia. And that's the reason now you have got two SCJs. One is the original SCJ and another one is a new SCJ. Now, new SCJ is identified by bold line, which you see on an acetic acid application. So whenever you're doing a colposcopy, even though everything is looking so much clear to you as a TZ1 or might be whatever, with a normal saline, I still will tell you all to tell about the new SCJ only after applying acetic acid and not before that, even though if it is very nicely seen also. So you have this transformation zone, which is the distance between the original and the new SCJ. Why are we very keen in learning the SCJ, the transformation zone? Because our lesions has to arise from the new SCJ within the transformation zone. And that's why so? Because HPV is an epitheliotropic virus. It requires dividing cells, and hence your lesions come from new SCJ. So that's a clear understanding. So even if you have a satellite lesion, you will not be worried because it can be because of the low grade HPV or a flat condyloma. So you don't have to worry about it. Now, when you talk about TZ3, you have it on the os. Okay. So what is a TZ1? The TZ1 is when you see everything very clearly on the ectocervix. What is a TZ2? You can see a thin layer of endometrial strip. All right. But you can see very clearly the bold line near the SCJ, near your os. So this new SCJ is seen as a very clear line. You don't require any instrumentation to open it. But if you want to have an instrumentation to open and see, that's when your SCJ has traversed inside, and now that is TZ3. What is the clinical relevance of understanding these things? The clinical relevance is post-menopausal age group. You cannot give, you can't, rely on your VIA. Other thing, if your PAP is showing, say, ASCH or something HSIL or LCL, and you are seeing TZ3, you know that there is a lesion. But on a colposcopy, you're not seeing anything. That doesn't mean that there is not a lesion. So have a relevance, have an amalgamation of your tests along with your colposcopy. That's exactly where we call it as a preventive oncology subject as such. And this is the relevance. Now, this is what I just told you. So this is the, distal crypt openings. This is only we'll see by crypts. And the more so people who have come and attended my hands-on courses will appreciate that. I make them understand first the distal crypt opening rather than jumping into understanding SCJ, the new SCJ. Okay. The more so, because that's how you will understand congenital TZ. Once in 40,000 patients, you see a congenital TZ. These are the googly cases which you will not know how to interpret. So when I had written my first book, I didn't know about this, and I had to do a lot of study and research to understand what was congenital TZ. And then when I wrote my second and I got a second case, luckily I've had in my lifetime 2 cases of congenital TZ. It was very easy for me because I follow these steps very correctly, without, very religiously for that matter. Now, this is another TZ1 where you can see the distal crypt openings, and this is your new SCJ after acetic acid, and these are distal crypt openings. And this is your transformation zone 1. Now, whenever there is an ectropion or an ectopy, what is the difference between ectropion and ectopy? Ectropion is whenever there is a lateral tear after post-delivery, your cervix opens up, the patient's cervix opens up, and then you can see a lot of columnar epithelium. But what's an ectopy? Ectopy is in the pubertal or the post-pubertal adolescent age group when there is a real outflow of the columnar epithelium till whatever the crypt openings. So what is the relevance about an ectropion and ectropion? That's again very important for all of us to understand. Whenever there is an ectropion, ectropion, your TZ is so little, it's so narrow, you know, that it would have gone till here. You would just get a small narrow patch to evaluate. It was very difficult to even go beyond and see. So you should be very, very adept into your colposcopy practice to truly practice preventive oncology. You might have a small lesion somewhere and you will not know that, oh, there was a lesion, because you are seeing everything red. So understand, dear friends, whenever there is an ectropion, ectropion, be very judicious, try to go around 360 degrees, find out whether are you seeing. And in my atlas also, I have given all tips and tricks of doing efficient colposcopy. Take an traumatic instrument like a sponge holder, dip the contralateral fornix so that the cervix falls down and you can see the upper edge. Many a times you see cervix is up here, down here, anywhere, somewhere, and you are trying to do colposcopy without even understanding that cervix is not looking at you. The cervix has to look at you. And then only please start your colposcopy. Otherwise, a colposcopy is a very simple procedure. Some might say, oh, what is there in a colposcopy so big that Priya keeps on talking about it? In fact, I will tell you, colposcopy is the biggest art. More than a science, it is the art. It's the art of identifying certain things which truly might not, be relevant. But then when you take a biopsy, you would understand, oh, it was SIN 2. Oh, it was an LCL, which was just missed out. So many things. Or many times it is overdiagnosed, metaplasia. Every metaplasia, many of my students have said, madam, this can be a lesion. So art is to understand. Now, this is TZ2, where you have this SCJ near the os, a small strip. And even before I even go to green filter, you can see all the many, blood vessel patterns. So the people might say that this is many of my candidates who have come for my training programs are also doing hysteroscopy. Even I do hysteroscopy. So when we do, people ask, ma'am, why do you require a colposcopy? I can see the cervix so nicely with my hysteroscope. I just put my hysteroscope and I can see even endocervical cells and all that thing. Very true. I don't deny the fact. Even I enjoy looking at it. But there is certain terminologies called green filter where you really will understand blood vessels, and they are the basis. At least for me, it has helped me tremendously in my practice by understanding blood vessel pattern. This is TZ3 where you're not able to see anything. It's an atrophic epithelium. Look at the patches, pedicle hemorrhages. It's an atrophic one. Hence, it's looking that pedicle hemorrhages have come up. Metaplasia, as I told you, it's a subcolumnar totipotent cells, which is dividing cells. And that's the basis of lifting up your single layer columnar epithelium and forming a multiple layer. And so we have over here as a chart that columnar epithelium. First, it goes into immature metaplasia. What is immature? It is still growing. The upper layer has yet not got stratified. That means glycogen hasn't yet come up. And then eventually it will develop glycogen granules, and that's where it becomes a mature metaplasia. Otherwise, if there is an infection, as I told you, HPV is an epitheliotropic virus. It tries to, gain those dividing cells to have that, life cycle on. And that's where your dysplastic epithelium comes up. So natural history you have seen the CIN1 regresses, CIN2 also regresses, but there is still a progression, and SIN3 definitely is high. Now, ASCP 2019, now I'm writing my third book now, third edition, because my second edition is almost on the verge of completion. The books have all sold out. So I was writing the chapter, and I'm on it, where I've written about clinical implication of understanding the guidelines very well. How will you put up your cases into each bracket? That's very important. And that's exactly, we have to understand that, the indications for colposcopy. Now, indications of colposcopy has changed as per newer guidelines. Even unhealthy cervix. Initially, it used to be screen positives taken up for colposcopy. But now unhealthy cervix also can be taken up for colposcopy. This is a very important landmark guidelines decision which has come up in ASCP 2019. And also another wonderful step which has come up is take 4-quadrant biopsy. It's again a landmark history which has come up because of the KPNC data they worked on for 1.5 million ladies for 15 years, and then they found this type. So that guidelines is really beautiful and wonderful. Now we have steps of colposcopy. We all know about it. Take a consent, use the right type of speculum. Another thing is, don't start even before, there is not a, you have to fix it first. Do not start and waste your time. That 1 minute of thing is very, very important. So you first clean it with normal saline. You look into the crypt opening. You will try to find out whether there are any abnormal hyperkinetic patch or polyps or anything. Then you put a green filter to look into the blood vessels. You put a 5%. Then another thing, very important, switch back to white base. Now, in my 30 centers where we give coded report and I see all the reports, many a times it has so happened that my centers have not switched back to green filter. They would have just gone green filter. They would have just pressed the same button, come to GF1 and did a colposcopy. And they asked me to interpret or code that, validate that report. It's very, very wrong, because you do not then get any identification of aceto-white area. Believe me, friends. Because I've been even coding for, in a day, I actually give 50 colposcopy reports from all my centers. So here we have to be very, very particular in understanding the colposcopy, and then Lugol's iodine after that. So let me come quickly take you through these steps. So first is normal saline. Try to identify the distal crypt opening. The middle one is the os, and do not now be in a hurry to talk about new SCJ. Then you go with the blood vessels. Now, many a times, I tell you, many a time, I'm an ardent fan of blood vessel. And the people who have come to me to learn, more than 1,000 gynecologists have come for my hands-on courses. They would have seen the passion in me when I talk about blood vessel. And even they fall into the same trap of passion, of understanding the blood vessel in a more systematic manner. Because blood vessel is one thing which actually tells that the previous history also. Say like this is a long parallel blood vessel pattern. If you find this long parallel blood vessel pattern, you're sure that this lady has undergone some treatment in the past. This is very common, in a menopausal age group. It's a hairpin bend pattern. Then you have over here this long tree branching pattern. I had a case with a multiple, Nabothian, and they were talking about doing a hysterectomy, thinking that it's a tumor. 2 gynecologists had said it's a tumor. And it was a very shabby looking cervix, very shabby looking cervix. She had come to me for the last final decision. And just looking on that blood vessel pattern, I took a needle cautery and did a marsupialization. Within 2-3 months, everything clear. So very important for us to know these blood vessel patterns. Now, these are reticular blood vessel pattern. These are branching pattern. So over here, I brought for you, see, look at the tree branching pattern on the Nabothian. Then I brought for you few, I do not know how is the interface and are you able to appreciate on your screen. But then these are all the reticular blood vessel pattern, which are again a very common pattern. Now talking about the abnormal blood vessel pattern, again, this is like a guru mantra. If you see these things on the aceto-white area, you're for sure that you're heeding for a microinvasive seal. So that's one thing very, very important. And very particularly, you should be able to. But another thing I'll tell you, when you're putting a green filter and try, if you would have found a solitary abnormal blood vessel pattern, all right, keep that in your mind. Go ahead doing your complete steps. And if you do not find any aceto-white area subjugating the same place or identifying in the same place, do not put more attention to that blood vessel, because it is not having everything under one thing. So your abnormal blood vessel pattern, your aceto-white area, your Lugol's, like everything should be under the same area. Then you will give importance to it. So here we have over here corkscrew type of pattern, then mosaic patterns, and also breaking mosaics. Now, another very important thing, breaking mosaics can give you, even before your histopath, you can be very sure that this is heading towards microinvasive CA. So your eyes should be tuned to look into these patterns. And then you have different types, on that aceto-white area, I've shown you tendril pattern, a corkscrew type pattern. And my third, this thing in the GF2, very important for all of us to understand. Come back to the white base, make a fresh acetic acid, 24 hours, you should be making it. Another very important thing in a colposcopy. One of the doctors had got trained, and he was so much, he read the whole book he did make me also sleep. Every half an hour he used to give me a call, so much passionate. After learning from me, he goes, he purchases my book, sits at the book at night at 10 o'clock till morning 5 o'clock, and he's keeping on calling me. So I'm giving an extended lecture to him even in the night on the phone. So this guy, so much passionate, next day he goes to do a colposcopy. And I get a phone call from there, frantic phone call. Are Priya, uska to vagina jal gaya. His vagina, her vagina has got burnt. Why? Because you didn't give the right instruction to your staffy. Your staff knows you said 0.5, 9.5. But please tell the right thing. 0.5 of what? 9.5 of what? And I might sound very silly to you all, but these are all from my practical experiences. And again, while telling your juniors to substitute, to make this freshly prepared one, tell them to be very cautious. Many a times I have seen acetic acid spilling on their hand. So they are very much, so making this, try to make it yourself and then show it to your staff nurse how to make it. So this is your preparation, 0.5, 9.5, 1, 19.5, 95 of what? Distilled glacial acetic acid to distilled water. Now, how do you understand if where does our expertise lies? Is it on looking into a high-grade lesion and saying, oh, great, I have found a high-grade lesion? This so even your paramedic would do. Why do you require a great colposcopist to look into that and give a big this thing? You don't have to become very complacent by finding a high-grade lesion. Your expertise lies in understanding metaplasia from a vis-a-vis to a low-grade lesion, so that you do not overtreat nor you undertreat. So how do you understand a metaplasia? Thin, shiny, translucent, without any set geographical pattern, arising anywhere. It can arise from columnar epithelium as well, appears and disappears fast. So you will apply for 1 minute, and 1 minute is that magical time when you will note, you will note the differences. In that 1 minute of magical minute, don't keep on looking head up here and down. Be focused on that cervix. You never know when a low-grade lesion will erupt. So after applying acetic acid, you will first try to look into the newer SCJ, you look into metaplasia. Many a times columnar epithelium turns white because of metaplasia. Satellite lesions will come up, congenital TZ, as I told you. Many a times these will be congenital TZs will be identified by aceto-whiteness elongating into your fornix. So anterior and posterior vaginal fornix, you will have that aceto-whiteness seeping down. So that's congenital TZ and hyperkeratic patch. So what's a metaplasia? Let's go to this slide. Thin, shiny, translucent, without any set border. Merging with the rest of the tissue, cloudy in appearance. Pathological, as I told you, low-grade lesion appears little late. So be very prudent in observing that 1 minute, very important, that 1 minute of observation. So you get that aceto-whiteness erupting slowly, but it comes from SCJ. That's very important. It is opaque, it is not translucent. It might have feathery margins vis-a-vis to your metaplasia, which is again like, feathery or budging with the rest of the tissues. And high-grade lesion is definitely an oyster egg white. High-grade lesion cannot be missed out. Leave apart even describing it. It's thick, dense, chalky white. So pathological VIA, all these things are there. So here you have all these this is a thin aceto-white area, but it is opaque, it is thick, raised one, it's a circumoroficial one. Then try to remove the extra acetic acid from the fornix. Do not put in a big hurry Lugols directly from the bottle, because it is going to get diluted. Why? Because you had that extra acetic acid on the fornix. What is the principle of a Lugols? Epithelium which has glycogen definitely will turn mahogany brown. So you have a physiological one where, all this squamous epithelium, then your mature squamous metaplasia, these will all turn brown. But in a physiological condition which will not turn brown is atrophic epithelium, immature metaplasia. So here we have a complete picture. Now, why is this looking saffron? It is not saffron, it's just taken up. It's just painted and it will wash away. That's your columnar epithelium. Many people have a lot of confusion in understanding after Lugols it is looking, is it, madam, why is that turn like that? So understand one thing, columnar epithelium doesn't take Lugol's, but it will just get painted and it get washed away. That's your, again, pathological conditions of CI and lesions, then trichomonal infections you see over here. You have this as a lesion, you have this as this is your os. So first try to identify the SCJ and the os. This is trichomonal infection. This is again your os, and this is your SCJ, and this is a satellite lesion. Do not worry about the satellite lesion. Pay enough understanding about the lesion pattern arising from SCJ. This is again the SCJ with lot many lesions. I've got a procedure for colposcopy, and let's see. First, we are cleaning it up. So after cleaning, we are going ahead. We have applied normal saline. So you can apply it with normally people who have come for my training courses. This was in a camp setting. I took this video. I normally use sponge holder with cotton balls. So that's how I use. You can use syringe also. The people have used that also in a camps. So now remove the extra normal saline. Then we focus on it. Go zoom, focus. Try to identify the distal crypt opening. Otherwise, I'm not seeing anything. Then I think I have just skipped that green filter for you. Okay. So green filter. So we have 3 types of green filter in boards, 5 types in Promise. EVA has 1 green filter. Then after that, after identifying that, put a timer on. EVA timer is, EVA is a more of a screening device, but it's also serving the purpose for doing a colposcopy. EVA goes downwards, but in these colposcope, it is upwards. So from 0 to 60 seconds, and then you can go, it's like that. EVA has another way of understanding, it goes descending down. So these are all the differences in various tools also, I'm saying. I have got all the tools with me in my this thing, clinics, in my hospital. So, but you can ask me, what are you finding comfortable? I'm finding comfortable with everything, because colposcopy is to be understood. Machine is not going to teach you. Your understanding is what is going to make you understand. The main thing is your HD colposcope should be good enough to give you a nice zoom and, you know, understanding the case well. So here what we are seeing is after application of acetic acid, we do have this SCJ to be identified. So this is my new SCJ, which is a bold, nice. I can see this line. Now here also you will see everything is looking white, 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 white. Why is this? These are all metaplasia. How do I understand a metaplasia from a lesion? You can see this is a lesion which is from SCJ. It is dense, it is opaque with a regular set margin arising from SCJ, little raised margins as well. And now I'm taking you through 360 degrees. Here there is a dense acetowhiteness. Again, here there is an acetowhiteness, but it is cloudy. It's not dense. Again, you go taking you around this cervix, you will see, now I'm zooming in to make you understand the difference between it. And within few seconds, you will see that whiteness is also going away. All the metaplasia will fade away. Then you have a lesion arising here and a lesion here. All right. Once we have noted this, now this is a teaching video, so I've taken up till 3 seconds, 3 minutes. In 3 minutes, what you're seeing, the lesion will remain, whereas all the metaplasia will fade away. You do not have to wait for 3 minutes. Your 1 minute of interpretation is enough. EVA has another methodology. It goes till 4 minutes and then it descends down. So that is different techniques which has been built up by different manufacturers. You don't have to worry about that. Now, then you put a Lugol's. When you're putting a Lugol's, you don't have to dilute it. You don't have to time it. I have timed it just before you all to understand the concept of colposcopy. This is a teaching video. Again, I'm revising. That is no need to time. Now, what we do is, now, suddenly you're not understanding. Your lesion has merged amongst all yellowness and saffron color. You're not knowing what is a lesion, what is a normal tissue. This actually is the idea of doing a colposcopy in a systematic manner, understanding it well. Now over here, what I've done, I've removed all the acetic acid out, the extra Lugol's out, and I'm now focusing on my cervix. Now, what am I doing? I'm taking a zoom in, and I'm going to show you the color difference. As I told you, columnar epithelium, being a single-layered epithelium will not take it up, but look at the color difference. A lesion is more yellowish, more saffron, whereas these things are just painted. and the paint will vanish away. Now you will see quickly the paint vanishing and turning back to pink color. See, just wait for some time. All your doubts will vanish. You can see, and only the lesion part remains. So when you have identified this, you will do the sweet scoring. You will do the scoring. Why should you do a scoring system? You should do a scoring system to understand. Now, if you want to do a screen and treat program and you have a scoring above 5, definitely you will go for treatment. Why not? You can do a treatment there and then. So there we have, you can see at 1 minute, all the things that the paints have gone away. It's come back to the pink color. Take a good punch biopsy. Take a good punch. While taking a punch, I always have this exercise done for my candidates. I ask them to locate where will you take a punch from, and it has to cover SCJ. It cannot be from the mostly evidently looking mustard yellow color. No, it might look mustard yellow, but you have to have that SCJ within. This is a punch. You don't have to have a anesthesia or anything for this. It's 11 times magnified, so it's looking highly no vascular. Otherwise, it's nothing. See, I'm taking a good punch. You should have a good instrument with you. That's the basic thing. Once you have done it, put a tampon, keep her sometimes. They tell her to remove the tampon with a long thread in the evening hours after 4 or 5 hours. So that's the procedure. Now we have for you, and we will sweep these lesions. So you have a thin aceto whiteness of 1. Then margins are again 1. And this is in the, you don't have any abnormal blood vessel or coarse mosaic. So 0 for blood vessel. Then this is for, size. So 2 quadrants is 1 and Lugol's is 1. So you are 1 plus 1 plus 0 plus 1 plus 1 is 4. And then that's your sin 1. Again, now this is sin 2. This is sweeting to around 6 or 7. This is sin 3. And you can see over here the coarse mosaic pattern as well. If I have to sweep this, then it goes as dense aceto white 2, raised margins 2, then coarse mosaics 2. Is there in the 2 quadrants of 1 and patchy uptake 1. So it's around, say what, 7 or 8. Again, this is invasive CA. I told you, dear friends, about wide and hairpin pattern, comma type of pattern, corkscrew type of pattern. So many patterns identified, and this is a micro-invasive CA. Again, do not forget about adenocarcinoma. Even that's very common. And here, the metaplasia, which would have otherwise looked transparent, here the aceto whiteness looks dense. That's the difference. Look at the blood vessel pattern as well. And it is going endocervix. That's very important. Then you have a diagrammatic representation. And that's the sweet scoring for you. Instrument trolley. So this is the sweet scoring. You all can see that in this thing also, Google or in any of the textbooks. Instrument trolley is very important. A very important one is instrument trolley. You should have everything, on your instrument trolley before you start a procedure. Many a times, vaginal laxity, use condoms to ensheath, and then use it. Different types of speculum important. Biopsy forceps, very important. Endocervical speculum, extremely important. I do not start my things without these instruments. Now, this is my own development. This is my own patent instrument. This is PGK tissue holding forceps, which is developed for, in fact, to hold the cervix and pull it down and do a nice, and it's an insulated one for LETs and all that thing. It really helps. And then endocervical curette. Then this is your lateral vaginal wall retractor. As I told you, this was also highlighted in the yearbook of Foxy in the chapter where doctors have developed their own instruments. Then I've developed this type of bag also so that you become, ambulatory. You can go to traveling hysteroscopist or traveling laparoscopist, so like that, traveling colposcopist. So all the things can be done. Now coming to case management, you have ablative excisional therapy. Now I'll take you straight to cold coagulation, thermal ablation. This is, it's an in thing today. And I would advise many of you all who all are really interested in this subject, buy a thermoablator. It's a one-time investment, but it's worth that investment. So what it does is you don't have to have your cylinder and all that thing. It's a preheated one. You can heat it till more than 100 degrees centigrade. It actually evaporates the intracellular water, thus causing desiccation and thus causing denaturation. You apply it for 40 seconds at multiple places and you are getting your wonderful result. So you can see over here. So it's a beautiful instrument. You want to have a screen and treat, take it to your camps. I'm not giving any anesthesia, nor am I giving any local anything. It's just beautiful. You don't have to have that monocautery and that cautery and all that thing. Nothing. It's just simple. So it's very important that you have these instruments with you. You have the higher end technologies with you so that you can do justice. So if I talk about cryocoagulation, everyone are doing cryocoagulation these days. And I'm seeing so many patients coming from so many places without even having a lesion cryo was done. The other day, I got a patient from Dehradun, and she said, she was on my online consultation. She showed me her reports, and she said the doctor had done a cryo because I was having a lot of white discharge without doing a colposcopy, without identifying a lesion, without why do just because you have a gadget with you. Understand one thing, dear friends, doing a cold coagulation, I mean a cryocoagulation, sorry, cryotherapy should not be done in a chronic, in a cervicitis, acute cervicitis. Understand this very clearly. You are giving her more disaster because it is going to lead to PID. Hence, go systematic. There is no hurry. There's absolutely no hurry. So what you do is, what is the requisite, prerequisite for so the lesion should be within the cryo ball. It should not be an endocervical lesion. It should not be a very aggressive lesion looking like a suspicious cancer. Many times, coagulation, cryotherapy is also done for metaplasia. I agree to that because it's just a triggering factor, reversal of metaplasia, the stagnant one. So metaplasia occurs. Those are the cases where you might say ectropion or ectopy. There, the cryo ball will not have covered the whole red looking epithelium. Doesn't matter. But when that is only a reversal physiological process, you're assisting metaplasia. But when you are doing for a treatment, be very judicious. Otherwise, many of the cryo patients, they come back to you with a failure rates. So when I wrote my first book, I had taken the advantage of WHO stating quick, fast freezing, slow thawing, and fast freezing, rapid freezing, and all that stuff. That time I had written, it was their thing. They had said 323, then 353, and all that thing. Finally, when I wrote my atlas, I did a meta-analysis study to understand what exactly should you adopt, to get the effective cryo. Let me take you through this video to you. Now here the cryo ball is coming. The cryo ball, your instrument should be very nicely, the console should be nicely fit into the nitrous or carbon dioxide. Normally I use nitrous. It is, you give a 3 minutes of rapid freezing. What happens many a times? We are not in experience of opening the thing and seeing the visor. Many times visor are broken and most of the nitrous oxide is flowing onto your hand. It's not going onto the nozzle. So you're not getting that effective cryo. The effective cryo is, it should not be able to fall down. It should wait for some time till the gun detaches on its own. If it detaches very quickly, for sure your treatment is not effective. Either change the cylinder, look into the cryo gun, open up the cryo gun, find the visor. It might be broken, no effectiveness. So just don't do procedures for the sake of the heck of doing it. So the main thing is, see here, what I'm done. It has detached on its own. Now I'm waiting for it to defrost. I'm not putting the timer. Timer is just it is just going on. But I will wait till the frost gets defrost and it is gone into its own pink color. So then only apply the second thing. So what is the principle behind the cryo? The inside temperature is -60, -68 degree for that matter. Outside temperature rim is -20 degrees centigrade. It actually dissipates or crystallizes the intracellular water, does denaturing. See here, waiting for the color to come back. Again and again, I'm repeating the same thing. Why? Because it's very important if you want to have a effective cryotherapy. And so then you can apply second time and that's it. What is the thing which you say after cryo or after thermo or any procedure? No sexual contact for at least 1 month. No douching, no application of any pastries or anything. Because it's a raw area, HPV gets more, quickly manifested, or it takes up the root if there is a sexual contact done over here. So here it is defrosted and then only you will apply. So that's the beauty of, and what is the disadvantage? There will be a lot of watery discharge. So the patient might tell you that, oh, I was very happy before and now you're giving me a lot of watery discharge. So you have to tell the patient that this type, the abnormal cells are washing away with the water, something of that sort, so to convince them. And we all know that it's a defrost in the intracellular water crystallization is coming out as water. So see, it's taking such a long time for this. You are seeing the color has really changed beautifully. And then only I'm going ahead doing a second time application. So that's with your cryo. And you have got this results, wonderful results. Then we go to LEAP. It's an excisional procedure. It's a monopolar cautery with it has to have that complete circuit on. The currents which we use is cut current, squag, and blended. So that's a blended cautery which we use. So I brought a video for you on this LEAP. And normally this has to be done on a intracervical anesthesia, local. You will not give paracervical block. You will not give local sedation, nothing. Normally in my this thing, I'm noted for LETs. I've been giving a lot of demonstrations pan-India for LETs, and people come to learn from the fellowship course across the globe to learn the LETs technique from me. So you all will, whoever have come will have understood that it has to be done with a peace of mind. First of all, you be peaceful. Do not have a havoc created, because once it starts bleeding, then it is very difficult to control. I'm not trying to scare you all, but I'm trying to give you the whatever success story which I have envisaged in my journey in this past 2.5 decades as a colposcopist. I'm telling you, just giving you that hint. So here, first do a colposcopy. It's not that the previous colposcopy report you do a LETs. This is again another thing. Whenever you're doing a LETs, repeat it again, repeat the whole procedure. See, this is how exactly I do with my application of acetic acid. Now I'm applying, now I'm seeing there's lesions. You can see lesions here. You can see a big lesion here. I've used insulated cascos with a spout, which is connected to smoke evacuator or your that suction machine. And then now I'm applying Lugols. Okay. After this, what am I doing? I have seen that these are the lesions. I'm taking a 22 gauge spinal needle. You can use a dental needle as well, but I am more used to this. And 2% xylocaine. Use it very judiciously. I use it very conveniently, 10-15 ml. I had tried every possible thing by giving vasopressin, adrenaline, everything along with this 2%. But finally, I came to a conclusion. I'm more convinced that I don't have to have anything else. Just plain 2% is enough. Now you see, and I've given completely. Even a small prick is causing so much of a bleeding. Imagine to cut the whole chunk out. So you're using a blended cautery. You're using the desiccation current. Slowly going up. Now this is charged. This is a cropped video. I take 30 minutes for cutting a small chunk. Why? I go very slow. Second thing, whenever you're removing it out, another mantra, do not be in a hurry to pull. Never. Go till that end. See, the instrument, the loop which is there, it will bend. It's a very natural thing. It's made up of tungsten and it will just bend. What you have to do is come back to parallel to it and then remove it. Perpendicular. Then go back taking another pass. So you can take a pass from down to up or side to side, but never from up to down. Now, even with so much of a cut, you are seeing there is no bleeding at all. Why? What is that magic? The magic is going very slow. The magic is using desiccation. What is a desiccation? It's not a desiccation current, it's a fulguration methodology. Fulguration methodology is the charged electrode should be kept near, before even giving you a pass, it should be kept near the place from where you're going to cut, okay, for at least 2 to 3 minutes. So that's a fulguration effect. And then first you go inside, dip inside, and then slowly cut. So this is all taught in my fellowship courses on live patients and on workstations. You see, this is the wonderful leap done, and patient is completely clear. Another case I can show you. This is one case which I wanted to tell you. Look at that ectropion, big size. This is all columnar epithelium, and the lesion is actually above. I would have missed out this lesion had I not gone doing a proper thing. And now that lesion has spread within a month. And here this thing is taken, leap is taken. She comes, normally what we do is post leap, we call after for a relook colposcopy at 6 months. But here this patient was very much worried. And so she came to me at 3 months itself. And here you can see the parallel blood vessel pattern. This itself gave me an understanding that wonderful, my tissue has got healed. So definitely, friends, we do not have a dead end. We have a evidence-based practice these days as an alternative ending. These are all the reference textbooks. Now within 6 months, my 3rd edition also will come up of this book for which I'm writing. So effective hands-on training is the main thing. You can learn by online. You can learn my online classes. Already 350, 400 gynecologists have attended since the COVID period. Revati madam's daughter also had attended. So all these things are there, but they will not give you that much of an effectiveness until and unless you really sit behind the colposcope and learn. So friends, yes, early detection can save life, and then let's all join hands together. And I'm very happy to say that after taking up the post of oncology committee chair and after this SSNPP webinars, almost 159, 162 societies have been covered up in giving the training, the much required training in screening and VIA and all that. And I'm sure that many of the Foxians will join hands together and into the journey, embarking the journey to make cervical cancer free India. So thank you very much for patient hearing.
Thank you, Priya. It is wonderful as usual. And I always admire your passion in reaching and teaching the gynecologists to learn and practice colposcopy. Usually, previously, it was thought to be a dry subject, management of cancer cervix. You have made it very lovely and lively and developed interest in every gynecologist to take care of this preventive oncology. Thank you very much.
Thank you. Thank you, madam.
Sampath, shall we move on to the next talk or any queries? A second talk.
Madam, I'll take your permission and I'll leave. Thank you very much.
Thank you, Priya. Very nice.
Thank you, ma'am.
I'll inform you regarding the Madurai workshop later. Okay, thank you. Next topic is on hysteroscopy and procedures. Can I have Vanita's CV, please? Dr. Vanita CV. Dr. Vanita, Director, Sunrays Laparoscopic Center, Chennai, and she's a teaching faculty EISC Chennai and Managing Committee member of OXY. She's also EC member of Tamil Nadu Factor of IAGE, Coordinator of South Zone Foxy Endoscopy Committee. She's a winner of Foxy Dr. Sauli Rudra Sinha Award, Best Doctor Award from GPS Society in 2018, Best Paper in 14th International RCH Conference. And she has presented several papers in national conferences, and she's a coordinator for various pre-congress workshop on basic laparoscopic skills. And her area of interest include advanced laparoscopy, hysteroscopy, and fertility enhancing surgeries. Over to you, Dr. Vanita, to discuss the hysteroscopic procedures. Dr. Vanita.
Ma'am, I think so. There is some network issue. Ma'am joined again.
Okay.
Good evening, ma'am. I'm just having a little trouble with my network. Just a second, ma'am, before I set it right. Achha. Ma'am, is my screen visible, ma'am?
Yeah, we can see the last slide.
Okay, ma'am. Good evening, one and all. At the outside, I thank TNFOG, President Anjalakshi Madam, Vice President Revati Madam, and Sampath Kumari Madam for having given me this wonderful opportunity to present on hysteroscopy. As we all know, there's a lot of hope and there's a ray of hope beyond the scope today. And there's a paradigm shift in the way gynecology is being practiced, from laparotomies to, scopic procedures. We are going ahead with daycare hysteroscopy, and I think we are at the trend where we are going to have one-stop clinics. That's the trend which is really catching up today. And every gynecologist needs to have a thorough knowledge of hysteroscopy in her day-to-day practice, as much as what every obstetrician has with regard to ultrasound. So there's no way by which we can get away in our routine gynec practice without a sound knowledge of hysteroscopy. And that's the basis of my talk for the next 30 minutes. By definition, hysteroscopy is the examination of the inside of the cervix and uterus using a telescope. If I have to put it, it's just a sneak peek into the uterine cavity. The common indications for doing a hysteroscopy is infertility. We have to have this hammered into our head. Whenever we do a laparoscopy for any case of infertility to evaluate, it is mandatory to also do a hysteroscopy. I see many places where a patient is just posted for laparoscopy. The tubes are tested, the ovaries are drilled, or the ovaries are addressed the way they want, and the POD is addressed. But many a times, a hysteroscopy is overlooked. That should not be the way. There is so much of information that we get from the hysteroscope. Not just the abdomen is a Pandora box, the uterus is also a Pandora box. There are many things which you cannot pick up even by the best of the imaging modalities. Micropolyps, signs of endometritis, signs of tuberculous endometritis are all best picked up when you do a hysteroscope, which is a very simple procedure and every single gynecologist can master it. Another area where we have a lot of scope with regard to the usage of hysteroscope is the evaluation of a patient with abnormal uterine bleeding. What we routinely do is a 2D ultrasound. We look at the cavity, and there's more information which we get from a 3D ultrasound. We do a PIPL, we do a time-tested DNC and many things, but we also always should remember there's nothing as good as looking and treating. The policy of see and treat is something which we have to get adapted now, and we have to change ourselves. So the best way to evaluate and the gold standard for any patient with abnormal uterine bleeding is the hysteroscope. We don't have to really get to anesthetizing her and putting her through the OT list and do it. We have gone really forward that we can do office hysteroscopes at the comfort of the side rooms and give the patient the best treatment. The next area is evaluation of postmenopausal bleeding. We have one-stop clinics for postmenopausal women where the woman comes with a history. You take a clear history, do a clinical evaluation, you do an ultrasound to her. When you find a thickened endometrium, as I said, you could do an office hysteroscope, take the biopsy or look at the lesion and treat her the same day in the same sitting. The entire procedure hardly takes right from the patient, the time she walks into the clinic, where she does the biopsy or she does the small polypectomy, or if you have a suspicion of cancer, you get a biopsy done, or you just reassure and tell her everything is fine. Within a span of 2 to 3 hours, this could be done. Next is suspected Mullerian anomalies. Again, as I said, whenever you have a Mullerian anomaly in suspicion, you have to have a laparoscope combined with a hysteroscope, even if you have the best MRI to tell you what it is. The confirmation is only by a hysterolaparoscopy. Many uteruses, for example, there are some very rare anomalies like your Robert uterus, the Ovira syndrome, which can be picked up only by hysteroscopy. Foreign body removal, the commonest foreign body that we get in our day-to-day practice is the puppety. Common operative procedures like proximal tubal cannulation, metroplasty, septal resections, polypectomy, myomectomy for figure stage 0, stage 1, and some of us even push our boundaries to stage 2 myomas can be done at one sitting. Adhesion lysis, though a level 3 procedure by RCOG guidelines, is something which we have to learn and practice. Again, for thin endometrium, PRP injection could be done. The results are better when you do it under hysteroscopy guidance rather than just injecting it in OPD blindly. There is no thing saying that we do a diagnostic hysteroscopy one day and then call a patient for operative hysteroscopy later, unless and until you're really caught unaware and you're not with the instruments. It has to be made mandatory, and all of us have to get into this practice that there's nothing called as diagnostic hysteroscopy. You do a hysteroscopy and proceed. You look into what is there, and if you have a positive finding, try and treat her and complete the procedure in the same setting. When it comes to scopies, as much as knowledge of the procedure, a knowledge of the equipment is also essential. So a quick look at what are the basic instruments that our hysteroscopists must have. Telescopes of varying size between 4 mm, 2.9 and 1.9 mm. As I said, office hysteroscopes are done with small caliber hysteroscopes. You have a 2.9 or a 1.9, you can happily start your office hysteroscopy unit. You have to have a good light source, a camera and a monitor. You have to have your diagnostic sheet. This is your diagnostic sheet and these are the operative sheets. When you have operative sheets, you have a continuous flow irrigation, which has the outflow channel and an inflow channel. And you have a instrument chamber, which allows 5 French instruments like your scissors, grasper, biopsy forceps, and hook electrodes like the ones which are shown here. So you can complete small procedures using this channel. Like you can do a polypectomy, you can do a biopsy forceps, you can do small septal sections, you can do additional lysis also to some extent with this operating system. But if you want to push yourself to do little more procedures, like you want to do a myomectomy, you want to do a TCRE, you want to do a big septum, complete septal resection, then you need a resectoscope. Whatever be the procedure, operative procedure you do, you should always have a good fluid delivery system and proper energy source, whether it's a monopolar or bipolar, whatever resectoscope you're going to use, you should have the appropriate energy source and a sound knowledge of the energy source, especially when you're using a monopolar, because otherwise you can get into complications with regard to the use of energy. We should always remember to have a return plate grounded properly. Your instruments should be checked for insulation. All this knowledge is very, very important before we start operating. When it comes to distension media, the commonest one that we use is normal saline, which is used for diagnostic purposes. And when you're using bipolar as an energy source, you can use it for operative cases. When you're using monopolar, the commonest distension media that we use is 1.5 glycine. With regard to the delivery systems, gravity method, that is, you just suspend the bottle at a distance of 3 feet from the patient's spot and you start pumping. This is what we see commonly in most of our OTs, and that is good enough to do a diagnostic procedure or maybe remove a copper T or just take a biopsy. But when you want to do operative procedures, you must have access to a pressure bag, and the best one is a hysteromat because it delivers a fluid at a graduated manner. So you can't do a laparoscope without an insufflator because carbon dioxide should be going in at a monitored rate. Similarly, you must have a hysteromat to do an operative procedure, especially if you want to do large myomas, you want to do a TCRE, you must know at what pressure the water goes in, how much fluid it's going in, and how much of distension you're going to create. Because all these play a big role in deciding how much of fluid deficit is there. And that is very, very important to keep our complications at bay. You want that? See, the standard way by which all of us have been doing hysteroscope over the years is we put the patient in a lithotomy position, we put in a speculum, we take a tenaculum, hold the cervix, and then we start dilating it, and then we slowly start pushing in the hysteroscope and we start visualizing. Does this mean this is the standard way, or are we all going to stick to it? Is that technique free of complications? The answer is no, because as you put in your tenaculum, you can cause cervical lacerations. When you start dilating, you can cause perforations. When you start pushing in with pressure, you can start creating false passages. Is there a way out to do this? Yes. That's the technique of vaginoscopy, which has been developed over the years with the no-touch technique, which uses small caliber scopes. There's no need for a speculum or tenaculum. The technique is so good that the 2020 ACOG committee opinion has approved vaginoscopy as a preferred method and the only method to prevent entry-related complications. This is the ideal technique to be followed for office hysteroscopy. And this has an advantage wherein you can look at the posterior vaginal wall, you can look at the anterior vaginal wall, you can look for endometriotic spots in the posterior wall. You can have, overall picture or first level screening of the cervix, though not as much as what Priya Madam described. And, she was phenomenal in the way she was describing things. It will not definitely give us so much clarity, but it's just a way of screening to look at the cervix and the cervical canal. All that you have to do is you have to take a small caliber hysteroscope, just connect your water inflow to this, and then ask your assistant to grab the labia and close it and start pumping in saline. This could be done even by the pressure method, or you can use your hysteromat. And as the saline is put in, the vagina becomes a cavity. Look at the posterior vaginal wall and identify the lips of the cervix. You can look at that by the cervical mucosa which is coming in. Then slowly follow the path. You have to wait for the water to go distend the cavity and then move it. See, as you go, you see only cervical crypts, then you know you're not the right path. Don't give extra pressure. Paucity of movements is the rule when you do a hysteroscope. Don't be very rude in pushing it. Gentle movements is all that is required. Identify the internal os, go step by step, wait for the water to create the passage for you, and then push your way in. The moment you see the ostium, it's a visual treat for any hysteroscopic surgeon because you know you're in the cavity. Once you're inside, then you will be able to do a 360-degree survey and then come out. See, this way you've seen that you've not handled the cervix, you've not put the speculum inside. So this gives the comfort of reduced pain to the patient, and you can even do it as a hysteroscopy procedure. This can be done even in virgins. The hymen is not really ruptured. I've tried it on a lot of patients and it has really worked wonderfully. See, when we do a diagnostic hysteroscopy, we need to remember certain anatomic landmarks like we should not push our way in. We should look at the external os. We should identify the cervical crypts and then go through the cervix. We should identify the internal os. We need to remember the circle. The internal os is not circular. It's an elliptical area. So we need to, manipulate our hysteroscope in such a way that we don't take the largest diameter and we take the shortest diameter. So you have to manipulate your Betocchi system in such a way you don't go anterior-posterior. You keep the oval tip of the Betocchi system along with the internal os and go your way in. So as you go in, first, always look at the upper crescent. When you look at the upper crescent, you will be able to go in right into the cavity. Look at the endometrium, look at the posterior wall, then go down to look at the fundus, look at the right ostium, then the left ostium, then the lateral walls, then the anterior and the posterior. All that you have to see is whether the endometrium is normal, whether the vascularity of the endometrium, is there strawberry spots, which are a telltale sign of endometritis, whether there's diffuse hyperemia, whether there's mucosal edema, any polyps that you have, any septum that you have, and you also can look for fibroids and all things. And as you withdraw the scope, similarly walk your way out. That is the time when sometimes cervical polyps come your way. The next procedure that I'm going to show you is a case of infertility when they come to you with a HSG picture of proximal tubal block. What do? We really do not have to take them for IVF candidates because when we do the HSG, we do not anesthetize the patients. We always know there's a factor of pain, rigidity, and corneal spasm which plays. So if we are able to cannulate the block and we're able to get away with clearing the block, these women can fall into the category of IUI or normal trial also, rather than falling into the category of IVF. So how do you do this? You put in your laparoscope and then start pushing in dye. You have to visualize first whether there's a block by pushing in at least a few 60, 80 ml. And then if there's a block, the level of the block. If it's a mid-segment, nothing is going to be done. If it's in the proximal segment, then go hysteroscopically and walk in your way with the guide wire and the cannulation sheath. Push the cannulation sheath only to the first 1.5 inches and not beyond that. And then slowly start pushing the dye. Blocks which happen due to debris or stenosis, then you have little sludge, then, like micropolyps can be cleared by this technique and which can be visualized by the way the dye is flowing out. But if it is fibrous or it is due to tuberculosis, it's due to chronic endometritis, those ones cannot be relieved. Similarly, if you have a block in the mid-segment, don't try to open up because it's not going to work. Tubes are not just rigid pipes where you just put in water from one side, it comes on the other side, it's going to work. Tubes are things which have cilia inside and they have to propel the embryo, and you should not also put the patient through an ectopic. So once short trial, if you're able to open up, fine. And if you're able to open up also, again, you should tell your patient that they have to get pregnant the next 6 to 12 months maximum. If they don't, they're not candidates for normal trial, they'll have to think of ART. By and large, the commonest Mullerian anomalies that we come across in our day-to-day practice are septum. Septum are seen across various, ages. You can see them in infertility patients. You can see them in women with recurrent pregnancy loss. You can see them even in women who have delivered but not have been known about it when they come to you and as a part of the evaluation of AUB. When it comes to a woman with recurrent pregnancy loss, yes, septal resection is done definitely without a second thought. In infertility, again, yes, we do. But when it comes to AUB, I don't think we really go ahead and sit and resect. There are various techniques by which a septal resection can be done. This is a partial septum. You can see we are going in with a hysteroscope. We have identified both the ostium and the mound in between. This extends only into part of the cavity and does not come down till the internal os. For these sort of septums and women with recurrent pregnancy loss and endometrial damage should be minimum. So what we're trying to do is we are trying to excise the septum with a scissors. Because when you cut it with the scissors, it's a fibrous strand or it's not going to really bleed. So you can get away with minimal damage to the endometrium. When you do these sort of septal resection, always start laterally and then come medially. When you have start laterally, you know your borders and you know the boundaries where to which you have to go. Once you've done the lateral boundary, the central mound is very easy for you to cut and go, like what I've shown you. The end point is the visualization of the pink myometrium, or when your fundus is at the same level as both the ostium, like what you can see here. This is how it's generally done. If it tends to bleed, never press the panic button. All that you have to do is you have to ask your assistant to just increase the pressure. So by increasing the intrauterine pressure, by increasing the flow rate of your fluid, the vascular channels tend to occlude. You have time to take in your roller ball and then run through. Not all septum are partial, or not all septum are thin like the one that was demonstrated. This is a complete septum starting from the internal os, and you have almost two cavities of equal size, could be sometimes, or sometimes unequal size. So when you have such large septum, it is not practically possible for us to cut it with scissors. So I've used a monopolar resectoscope here. When monopolar is used, the distension medium becomes glycine. So we need to be very, very careful about not getting into TURP syndrome here. And this is one area where we tend to work towards the fundus. So you have to have real good control over your instrument, because if you start giving big pushes, you can just perforate. Perforating with an energy source is not really something which a hysteroscopic surgeon would want, because we do not know what is there at the other end, and we can land up with costly complications. So you have to use your energy source, which could be the monopolar or bipolar. As I said, make small nicks, and the moment you visualize the pink myometrium or you feel that both the ostium are at the same level, you can stop. There are times we tend to undercorrect, but never try to overcorrect. That is when you get into the myometrium and the serosa and get into complications. This is supposed to be done in a single step. Gone are the days when people were doing it in 2 steps. You have to be very quick and swift. No septums are allowed to be done for more than 30 minutes, and the fluid deficit should be less than a liter. And after complete septums, there were times when people were putting in IUCD. That is taken off now, because we do not want to irritate the endometrium, because most of these women are fertility concern issues. So what we really do for these women is give them high dose of estrogen, progesterone. And if at all required, if you've done a complete septum and you feel an ultrasound, there's no proper lining, then you can call them for a second look between the 2nd week to the 6th week and lyse the minimal adhesions if at all present. Next comes the commonest one is a polypectomy done for polyps. Polyps are seen across, like abdominal uterine bleeding patients, infertility patients, even your patients for IVF. When you prepare them and you see the endometrium, you see a small echogenic area like this patient, what she was having. The first thing we try to do is remove off the polyp. You're in with the scope, you do a complete survey, you see she's got a little bit of Hashimans also, and this little one was always showing up on the ultrasound pre-IVF. So we went in with the hysteroscope and we saw a tiny polyp. So that's how it's being removed. The polyps on the anterior wall are always very easy to remove, because you have very good access from the posterior wall. You can shave a little bit of the endometrium and get away with it. The most difficult ones to be done with the scissors are the fundus, and the next comes the lateral wall because of the angulation. You're not really able to hit the base first. You can just shave it top and then go close flush to the endometrium, like what is being demonstrated here. Once that's done, you can either go ahead with your polyp grasping forces and remove it, or you can just leave it and tell the patient that it will get flushed out. Or the best way is to increase the pressure for a moment and suddenly shut it and pull it out. The backflow, the polyp just washes out and comes out.
For smaller polyps, you could do with this, but when you have a bigger polyp, especially ones with vascular pedicles, it's better to use a resectoscope. For very tiny polyps, which are less than 5 millimeter, you don't even have to use a scissors. You can just snare it with your grasper and pull it out. I'm not showing you big polyps because the technique of doing a big polyp is as much the way we do a myoma resection. When it comes to myoma, as I already mentioned, the type 0 myomas and type 1 myomas are the ones which commonly we do submucosal myomas. We have various classifications like the ESTE classification, the Lasmer et al. Classification, the STEP W classification. But I would always say Lasmer et al. And STEP W are things which we should really know as cystoscopic surgeons to decide whether this myoma can be approached best by hysteroscopy or laparoscopy. The various parameters that are taken into account when you do the classification of the size of the myomas, whether it's less than 2 to 5 centimeter or more than 5 centimeter, given a score of 0, 1, 2 correspondingly. The next is the location, whether it's in the lower segment, middle segment, or upper segment, 0, 1, 2. And next is the extension of the base, less than 1/3, 1/3 to 2/3, and more than 2/3. The penetration, if it's totally into the cavity, part of it in the cavity and more in the muscle, and if it's on the lateral wall. So you have a scoring and of 0, 1, 2 for all these parameters. If the scoring is anything between 0 to 4, then you know it's a low risk and it can be done very happily hysteroscopically. 5 and 6 are high risks, not to be done by beginners, to be done by experts. If beginners have to try, then you'll have to counsel your patient for 2 sittings. Anything more than 7 or even a cutoff of 7, it's best to think of alternate approach. That is a time when comes into your play the use of GnRH, your yearly Prestol, or then take the patient by laparoscopy. Again, another thing when you need to remember to do a myomectomy is when you have myomas of opposing surfaces, you have one in the anterior wall and one in the posterior wall, never try and resect them in the same sitting. Or if you resect them in the same sitting, please call them for a second look at the earliest by 2 weeks. Because when you're resecting them, you're creating damage both to the anterior wall and posterior wall. When you're doing both lateral walls, what happens is you're creating a artificial Asherman's and putting the patient into trouble. See, this is the way a myoma is resected. This is a type 0 myoma. As you can see, the size is almost more than 3.5 to 4 centimeter because the size of the loop is 5 millimeter. You can see we are able to get more than 6 to 7 times the loop. So we need to remember when we're doing a myoma resection to stick to the capsule of the myoma and stay within the myoma. When you touch the endometrium is what we do more damage. And it's always better to move the loop towards the telescope rather than moving away like what is being done here, because this needs a lot of control of movement. When we do this, we can really go and have the risk of perforating the fundus. Next complication or trouble that we have in doing the procedure is these bits tend to keep floating, obscure your view. So what we do is we pull out the resectoscope, we try to suck out the contents, and then we try to put it. Repeated, insertions and removal tend to create a lot of bleeding, and you have to flush the cervix, which means we're using more fluid. Another complication that can happen is fluid absorption, TURP syndrome, and sometimes rare incidences of even emboli are at risk. So is there any other way by which we can reduce this? Yes, we have a new kid on the block, which is the MyoSure system. The MyoSure system. This is a hysteroscopic modulator. I have no practical experience with this, but this will help us, get rid of the bits obscuring a vision. Any person who is just able to put in a diagnostic hysteroscope can go do this with ease. And even a myoma as big as 4 centimeters to 4.5 centimeters can be removed at one single sitting. All that you have to do is know to do a diagnostic hysteroscopy. Go place your blade on it, and you can see the rotating blade there. It starts to, evaporate and vaporize the myoma. So this, the entire procedure is very quick, and you can get away with it. Even a 4 centimeter myoma in one sitting, and the time taken and duration is hardly less than half an hour. Only thing prohibitive is the cost. The next thing is diagnosis of malignancy. When it comes to malignancy, any women, when you have an intermenstrual spotting and when you have some sort of menstrual pattern where it is not in coherence with normal, the best way to evaluate her is with a hysteroscope. you will have a lot of surprise findings. As I said, uterus 2 is a Pandora box. You can see papillary projections, you can see irregular areas, you can see focal areas of necrosis, focal areas of ulceration. This sort of vascularity pattern is pathognomonic of malignancy. There are diffuse lesions which you can find out. But when you have focal lesions, and if your DNC or if people misses out on that area, just like what is being seen here, that is the area where we can get into trouble. So a hysteroscope will help you take a guided biopsy and also will give the best modality of diagnosis to the patient. That's a focal lesion. And if you can see, this is a diffuse lesion. You have seen irregular surfaces. You can see the vascularity pattern is not uniform. If you look at, generally we have the first branch coming in, with the biggest diameter, and as it tends to branch out, the diameter of the vessels come down. But in malignancy, you can see all the vessels are disproportionate. Even the tiny branches are bigger than the main branch. So that is a telltale evidence to say, hysteroscopy finding to say, you should suspect malignancy, and 95 to 98% of the time it's malignancy. When you have such suspicious areas, when you have ulcerated areas like this, or you have solid papillary lesions like this, it is better to push in your 5 French instrument through the operative channel and take a biopsy from the area of suspicion. There's always two minds that whether this hysteroscopy is going to upstage the disease because the malignant cells might fall into the POD. If your hysteroscopy is done swiftly and you're going to complete the entire procedure in a few minutes, what I say a few minutes is never more than 5 minutes, I'm sure it's never going to upstage. We have to be quick and swift in doing this. Next procedure, which I always used to have wonderful results, thanks to Mirena, which has taken away the charm of this procedure, is the endometrial ablation techniques. TCRE was a real procedure which has saved many uteruses. Herein, you have to go in with your resectoscope and you have to use your cutting loop current with cutting current of 80 to 100 watts and take out the entire endometrium, including the mesometrium endometrium, deep down to expose the myometrium. This creates a sort of Asherman syndrome, and your patient with heavy bleeding for whom you have done the your endometrial sampling and you're sure she does not have atypia or hyperplasia, but still young in age where you don't want to remove the uterus. This is a wonderful procedure, but Mirena does the job so well now. So many of us are losing the art of doing this procedure. The only areas of difficulty which you would face in doing this would be near the cornua, where there will be trouble because they are the thinnest areas, more risky for perforation. And next is the previous LSCS scar. So for such areas, what you could do is a rollerball endometrial ablation. This is the rollerball of the hysteroscope. You can just run it over those areas or areas. This is the case of previous LSCS as I'm running it on the anterior wall. So the damage is less. And even if you have a bleeding as you're doing it, which really does not happen much, you can take time to, as I said, increase the pressure, get this rollerball in and ablate those areas. The next commonest thing that we encounter is the foreign body removal. Your patient comes in with a history of, a retained copper T, which has been tried to be removed using removal has been attempted by ultrasound guidance or other techniques, and then she comes up. You can do a hysteroscope by the vaginoscopic technique. Maybe you can prime the cervix with prostaglandins and then go in with a hysteroscope. This is a guided procedure where you take the scope and go just try to catch and come. Sometimes that doesn't work. Then what you have to do is graspers, especially ones which are impacted like this, go in with your grasper, try to disimpact it. That should be against or the opposite to the line of impaction. You have to pull it out and bring it to the cavity and then try to withdraw it. So this is a way by which foreign bodies can be easily removed. This is for impacted copper-Ts. For normal copper-Ts, you can catch the thread and pull it out. Or what you can do is you can push in your instrument through the loop of the thread, which is there at the proximal end, and pull it out. But I tell you, these graspers are very fragile. So once you try to catch them, they don't last for longer. Any woman who comes to you, as I said, with intermenstrual spotting or passage of clots or repeated episodes of bleeding, and she has had some sort of, obstetric history in the past, which could be a abortion or even after a delivery. If you have things like that and your ultrasound picks up something echogenic, don't go away easily with it. This is a common finding which is found, and this is nothing but a retained product. This retained product I'm just putting up because it was not easily coming up with the grasper, was not coming up even with the scissor. It was so adherent that it had even gained vascularity. See that I'm having to use a cold knife loop. I'm not using current, but I'm using my resectoscope to pull it out. So this is my hysteroscope. I've not used the energy source, but it was not coming with the grasper, so I had to use it. That is another technique of cold loop technique, which you can use for your myomas. When you have large myomas, you don't have to activate the energy. What you can do is you can start resecting, and then you can get into the capsule and just start looping out your myomas. So a part of it will come out, especially for type 2 myomas, and then you can start resecting it. These are all ways by which the damage to the endometrium is reduced. Another common thing which you can see is after especially second trimester abortions is these sort of opaque images which you can see on x-rays and echogenic areas in ultrasound. These are the small fetal bones which are left, can hardly be removed by DNCs. So the best way to remove it is with a hysteroscope. That is in a nutshell about the common procedures that we encounter in a day-to-day practice and about which all of us should have knowledge and should excel to give the best to our patients. The best way to excel at doing any procedure is to keep the complications at bay, for which we must have a thorough knowledge of the complications. It is always said it takes 2 years to learn what to do and 20 years to learn what not to do. And I would say it takes 10 years to learn how to avoid complications. So we should know what are the common complications: mechanical complications, electrosurgery related, patient positioning, and complications of distension media. Mechanical complications, we have cervical lacerations, false passage, uterine perforation, and bleeding. Cervical lacerations, as I already mentioned, we need to remember how the cervix is in a nulliparous patient and a multiparous patient. You should never give excessive traction on the cervix by using a tinaculum or a clamp, and forcible dilatation of the cervix is something which should never be done. Even if you're not doing a vaginoscopic method, you're just resorting to the traditional method of doing a hysteroscope. Do not dilate the cervix. Just go in and wait at the endocervix, wait for the water to open up, and then slowly follow the path. When you follow this method, not only cervical lacerations are avoided, also false passages avoided. The diagnosis of cervical laceration is very easy. Clinical examination is all that is required. Only in profuse cases you require a suture to be placed. Cervical lacerations can be, or the other way to reframe it would be, how do you prepare your patients for hysteroscopy? Do you really need to prepare? When you have small caliber hysteroscopes like 1.9 and 2.9, you really do not require. When you use large diameter like 4 mm, which comes with a sheath that becomes 7 mm, then you can use PG1 tablets kept, like in a parous woman, half an hour to 1 hour. In an nulliparous woman, 2 to 4 hours prior to the procedure. In severely stenoid cases, sometimes you have cases where they say they're not able to do the embryo transfer, and then they send them back for some sort of cervical dilatation under hysteroscope. In such cases, you can use your dilacervix or laminaria tent. Mostly we use dilacervix for dilatation. If you are caught unaware and you really find a stenotic cervix, does this mean you're going to be in trouble? No. You can use a Hartmann solution, which is nothing but vasopressin diluted in saline at a dilution of 0.05 to 0.1 unit per ml, 4 ml at 4 o'clock and 8 o'clock position, or your time-tested paracervical block will help you get over this cervical problem and help you do it. In case there are adhesions and synechia at the tip, you can just use your operative sheath without the continuous flow irrigation. Just use the inflow, use your 5 French scissors and start lysing the adhesions, and slowly you will be able to get into the cavity. The one way to avoid all these complications is the no touch or the vaginoscopy. As I already said, the next one is the false passage. See, this is the normal passage. If you have a Titan os here, what we tend to do is we tend to take a Hickas dilator and we start pushing. There will be sudden loss of resistance, and what happens is we have dug our way into the myometrium and we have created a cavity. We are not into the proper cavity. We go parallel to the gravity and we create it into the myometrium. Are we going to achieve what we want? No. So what we need to do is we need to use small diameter hysteroscopes, and I said follow the landmarks when you do a hysteroscope. This was a case where my junior, as I was doing the laparoscope, she wanted a hand with the hysteroscope and she was doing it. She just was going in with the hysteroscope. She couldn't, so she started dilating and she put it the traditional way. So when she went in, all that I could see was concentric layers of myometrium. We knew we were not in the right path. And the way to confirm it is you will never be able to see ostium here. Quick identification and coming out is very important, because if you start pushing in more saline, this will become a big cavity and you will never be able to come out, wait, and like what we are doing here. And you can see just above the false passage was the normal passage, which opened up and we were able to go into the cavity. And that's the ostium. As I said, visualization of the ostium is a visual treat to any hysteroscopic surgeon. So just follow the anatomic landmarks of external loss, cervical canal crypts, internal loss. Look at the upper dome of the uterus and enter. You will never get into this complication. The next complication is a uterine perforation, which can happen during dilatation, uterine manipulation, or sometimes when you push in the scope and you have a sudden loss of resistance, you can see that. Whenever there's loss of distension, there is a perforation, the distension does not stay because the fluid leaks into the peritoneal cavity. You will not be able to maintain the intrauterine pressure, even with the smallest. Even if you have a perforation with a sound, the distension does not stay because fluid always tends to take the path of least resistance. Sudden increase in fluid deficit, you're going on pushing and it doesn't come out because it's all leaking into the peritoneal cavity. And as you manipulate, you're able to see some yellow, pink bubble loops, you know you're inside the cavity. These are various videos of uterine perforation. Even in the hands of expert, it can happen. But the thing is to identify and recognize this complication. This is a case of septum. The septal resection was done with the scissors. And as you can see, they are sticking to the principles of going laterally first. When it comes to septum, there's always a big hue and cry as to whether we are incising the septum or excising the septum. I would say we are just resecting the septum. You incise here and the action is incision, but what we get is excision. So we are just resecting the septum. See paucity of movements, millimeter by millimeter, it's being resected. And always your fluid distension should be maintained. When you don't maintain that and you go 1 or 2 steps extra, that is what really happens. And you can see there's a big hole and you can see abdominal contents through that. Does this mean we can stop here? Yes. If the perforation is because of your knife or some mechanical reason, you can even stop the procedure and you can wait and watch to see. But since there was already a laparoscope inside, we visualized and there was an area of bleeding, you can just cauterize it and leave it. But the same is not the case when you have done the perforation with an energy source. This is a Collins knife using a monopolar resector scope. The resection is being done. As I said, we have to be very, very careful when we're doing a septum more than what we are doing for a polyp or a myoma, because there your movements are towards the telescope. So you will not have the risk of perforation. But in the septum, what you tend to do is you tend to move towards the fundus. So the risk of perforation is very high when you're doing a septal resection. If you are not looking at it very carefully done, but suddenly you can see there was a gush and the distension did not stay. So when we went in, what we saw was there was a big perforation, blood-stained fluid there, and this was again cauterized with monopolar. Sometimes you can even take a stitch if the bleeding doesn't arrest. Always, when you have perforated with an energy source, it is mandatory to go in with the laparoscope, visualize the area, not just the area, always the adjoining structures. If it's an anterior perforation, you have to look at the bladder. If it's a posterior perforation, you have to look at the adjoining bowel. Do a thorough bowel work. Look at the sigmoid. Look at the small intestines that is in the area. Look for any blanched areas. If you find a blanched area, if you find any area of where there's a breach in the serosa or mucosa, if you find anything yellow, fecal contents, please call in and do the appropriate management on table. These are the ones which can put us through difficult situations later. Not all perforations are, as gifted as this, where perforation is just restricted to the uterus. Sometimes this was a case where a fundal myoma resection was done. When they went in, this is a borrowed video. Thanks to Dr. Manjula Madam who has given me this video. What was identified apart from the fundal perforation was a serosal injury on the colon. If the laparoscope was not done, and for a hysteroscopy procedure, we never leave the patient niloral for long. We start fluids and orals in 4 hours time. This patient could have had a leak. So it's always mandatory. If you have had a complication with the energy source, go in, put in a laparoscope, do a thorough bowel work, look at the bladder in case of anterior injuries, and make sure there are no blanched areas and there are no injuries, to go have a good night's sleep for yourself as well as for the patient. And most of it I've already cleared. whenever you identify perforation, the procedure should be abandoned. As I said, small perforations caused by mechanical instruments can be observed expectantly. Tachycardia, hypotension, increasing abdominal girth, or signs of ongoing hemorrhage. And if this happens, we have to always be ready to go in with a laparoscope. When you have a large perforation and those ones caused due to active electrodes warrant laparoscopy. Stop the procedure. Always repeat the procedure and complete the procedure after 6 weeks, the time given for the wound to heal. Bleeding is a very infrequent complication, and even if it happens, you really don't have to worry, because all that you need to do is increase the pressure, and that itself creates a tamponade. You can take time to do your roller ball, set your roller ball in and go and cauterize the bleeding areas. You could do a uterine packing, or you could put in a Foley's with 20 to 30 ml of fluid and observe, which tamponade can be removed after 6 to 8 hours. Fluid deficit, especially when we are using glycine for myoma resections and TCRE, is a big complication which we need to really have knowledge to catch. There should be somebody in your team who is going to really sit and calculate the fluid deficit every 5 to 10 minutes. So one person has to keep a track of the fluid that's going in, and you have to connect it to a suction apparatus, or you have to have your drapes. You have to have the hysteroscopy sheet so that everything is collected in the drape, which is graduated, and you will be able to pick out the amount of fluid that's coming in. When you're using glycine, there should be a warning call when the fluid deficit is more than 750 ml, and you need to expedite the procedure, and you have to inform your anesthetist who will look for signs and symptoms of fluid overload. And you should draw your blood to look at the electrolytes, whether the patient is getting into hyponatremia. 1500 is a clear-cut indication to stop the procedure, and you have to observe the patient. The patient cannot be sent home like any other daycare patient. When you use normal saline, maybe you can push your boundary from 750 to 1000, and 1500 is a time when you take the warning, and 2000 ml is a clear-cut indication to stop even when it's normal saline. There are incidences not just of electrolyte imbalances, of even pulmonary and cerebral edema, and there are also cases of death reported. So we cannot just take this complication lightly. Your anesthetist will do a parotid lift, and the back tends to get really tight because of pulmonary edema. So they will start mechanical, positive pressure ventilation, and they'll start giving diuretics to clear up. If hyponatremia is there, then you will have to give double tonic saline. Hypertonic saline should be given to these patients. So this is about the common complications and the common procedures in a nutshell. Where are we today when it comes to hysteroscopy? Are we in a day of office hysteroscopy where we are just going to do it in the side rooms? Do we need to have a camera monitor to do all that? Do we have to have a big setup? Or are we real surgeons? We're just going to go in with handy devices. Yes, we have a new kid on the block, which is the EndoC. I'm a huge fan of this, and I've just done a few cases, and I've started falling in love with this instrument because this is the instrument that you need to carry. Very simple to assemble. This is the disposable sheet, which has the telescope and the light source at the end, and also a chamber from here where you can put in your 5 French instruments. You can do your small procedures like septum, polyp, foreign body removal. You don't have to have a camera. You don't have to have a light source. Your entire trolley is not required. Just this monitor is all that needs to be there. So you can just have your patient adjust the local anesthesia as required because it's a flexible tip, and you just need to connect your saline, and you just need to go in. Wonderful for daycare evaluation of abnormal uterine bleeding, for postmenopausal bleeding, and infertility pre-IVF hysteroscopes. You just go in, you will get the video record here. You can record the video, you can click pictures, and this is something which is going to be in the market. It's already in the market. Little prohibitive is the cost, but I'm sure every one of us will have it in the days to come, like what we have at hand Dopplers today. That's in a nutshell. And I would like to reiterate before I say thank you by saying that hysteroscopy is the gold standard for uterine cavity problems, and all of us need to excel into learning this art of hysteroscopy. Once again, I thank TNFOG for having given me this opportunity.
Revati madam, wonderful, Vanita.
Thank you, ma'am.
Both the speakers today have talked nicely, and it was focusing towards save the uterus, save the patient also through endoscopic procedures. Thank you. It was nice.
Thank you very much, Dr. Priya and Dr. Vanita.
Thank you, ma'am.
For your all excellent demonstrations.
Wonderful demonstration. So finally, we will go with the vote of thanks. First of all, I thank Dr. Anjalakshmi Madam for allowing to start the program, and the chairperson and the vice president, Dr. Revati Madam and Dr. Vidya Prabhakar for chairing the session, and speaker, Dr. Priya Ganesh Kumar and Dr. Vanita within a short notice. I think only 3 or 4 days back I told them. So fantastic video, Vanita. Priya, I think she has gone for another program. Anyway, it will be very, very useful to the audience. And as per registration, we have around 94 registrations. Within the 4 days, I think 94 is once again, I thank Shield Pharma for the scientific grant. Thank you.